So let's talk about that first new program, Advanced Primary Care Management Services, APCM. And at a high level, this is being referred to as an enhanced care management model. Other groups refer to it as the value-based care version of CCM. And so we always hear the transition to value-based care. Well, this program is really starting to do that. It has no minimum time requirement. And Kathryn, it's really a shift in how care management is approached these days, wouldn't you say?
Definitely. This is a new model. And I think this shift that we're seeing is this integration of multiple care management programs into a single framework. So at its core, we're getting streamlined care delivery, a more simplified billing process, all while we're improving outcomes for patients. So I'm very excited about APCM. And I think it's really building upon the existing foundation of care management.
And do you think it's very similar to CCM, or do you think it's kind of out there on its own? How would you describe it?
I think that there are enough similarities where everyone should be going into APCM with a lot of confidence. So there is still this element of comprehensive assessments. You're going to really be doing an in-depth review of patients' medical, functional, psychosocial needs. There's the incorporation of care plans that are whole patients, so less of just that specific chronic care focus. There's always this element of proactive care coordination. Providers are tasked to continue the care across specialists, facilities, and caregivers, making sure that continuity is there. 24/7 access. This is nothing new. This is kind of a hallmark of patient-centered care, making sure patients have access to that round the clock access to their team. Lastly, caregiver support, something that I'm really excited about, just that APCM is recognizing the critical role of caregivers and that kind of call out.
Kathryn, I like the way you consolidate it into these groups. For the record, the official list, Medicare published 13 specific elements. And as you were describing the similarities, a lot of people on the webinar can look at this list and say, yep, I do that, I do that, I do that, I do that. So I think for those of you who have CCM programs, you might see a lot of commonalities. Here's the rest of that 13-point list. You do a lot of these things. And so it's interesting how this new program combines a lot of those elements as well. Let's talk about some differences, Kathryn. So where do the programs kind of go on their own paths?
There are definitely a few differences to point out and be prepared for. So the scope of services, if you're really familiar with CCM, you will need to make sure that you understand PCM and transitional care management, really looping those all together and making sure that workflow is tightened up. There's also this element of population data analysis where you should have that ability to identify and address those gaps in care. That combined with risk stratification. So really making sure that you are targeting those patients who are higher risk and getting them the help that they need, which I think is, while it seems maybe a bit more of a challenge, what that does really help you do is target resource allocation. So you can focus your efforts on the ones who need it most and have that proactive engagement. So I'm not scared off by that. There is measuring and reporting performance. That's a component of this. That can look different depending on the organization. So more prep work might be required. Lastly, the billing structure and reimbursement. CCM has a single level code, while APCM offers this tiered structure based on care complexity and a few other things. Dan, do you want to elaborate a bit more on the billing components of this? Because I think that's some exciting stuff too.
Yeah, I think it's one of the big differences, and definitely on the top of my list. We talked about the CCM rates earlier, right? We said that CCM was about $60, $61. So here's what the APCM rates look like. It's based on 3 levels. So the first level is for patients with 1 or no chronic conditions. Level 2 is for patients with 2 or more. So this one mirrors CCM very well, but it pays about $50. Level 3, is for QMBs. We'll talk more about that in a second, but more chronic conditions with specific requirements. So you can look at this and say, well, that first level, $15, maybe that's not, the best use of our time. But the third level, that has a significant reimbursement. So what I like to do is, okay, let's put it side by side with CCM and then see what see what we're looking at. So, all right, there's my 60/49. And now here's where it gets interesting. If you did 20 additional minutes of CCM, you're adding this $45. So now you're at 105. If you did complex CCM, so like this level 3, this is the equivalent of complex, it's paying 131. So in its current form, a lot of the codes look better on the reimbursement side from CCM. But the one kicker, Kathryn, I think, is that you don't have to get 20 minutes or 40 minutes or 60 minutes.
Right. And that isn't something to just ignore. Patient engagement definitely has ebbs and flows. And that can be a huge drawback if you're not able to engage patients effectively, reach that 20-minute threshold every month. This might look a lot more exciting to you than the traditional CCM program.
Yeah, that's a good point. And especially that third tier, I think that's where a lot of folks on the webinar may be looking at that. Okay, how do I get the $110? That one might make sense for me. But there's a phrase in there, what, QMB beneficiaries. So maybe we should talk about what that is just to make sure there's no confusion. Okay.
I think there's some misconceptions. And I think that this is one of those steps where it's really evident that CMS is really focused on health equity. So let's learn more about QMB because it's pivotal in this model.
Yeah, and that's a good segue. And excuse me. So a QMB, it really stands for a Qualified Medicare Beneficiary. And a lot of people think that we're talking about dual eligibles. And so at a high level, you have Medicare patients, and Medicare is typically for older patients, and Medicaid is typically for lower income. And this is the segment of when they cross, right? So you have Medicare and Medicaid, but QMBs are only a segment of the patients that meet both criteria. There's also SLMBs, and I put in the notes at the bottom, that's a specified low income Medicare beneficiary. A QI is a qualified individual. A QDWI is a qualified disabled and working individual. So there's a lot of different types of dual eligible patients, but CMS has said for the purposes of APCM, we're only talking about QMBs. Now, QMBs represent about 85% of the dual eligibles. So there's a good chance if you have a patient in both, they most likely will be a QMB, but it's important to understand the difference. There's two types. One is a partial QMB, and the other is a full QMB. The partial gets the Medicare Part A premiums, the Medicare Part B premiums, Medicare coinsurance, and deductibles and co-payments paid. Full has a lower threshold to the national poverty level, and so they get a few more benefits. They also get the Medicaid covered services under the state plan. So if they're in partial or full, you can still be considered a QMB for the purposes of APCM in that level 3 code. Now, if you were to try to bill APCM level 3 for a patient that's not a QMB, your claim would be denied. So it's important to know, and you really don't have to do any formulas. A patient either is or isn't. They actually receive a QMB card, which will have an ID number. And so if they have one, they're a QMB. If not, they're not a QMB. So I would hope that for a lot of you, you have this type of information in your EHR or your billing software. But I would say for the purposes of APCM, we might want to know what your patient population looks like. So that's usually a good step in analyzing it. So I think, Kathryn, you talked about one of the favorite things about this program is that you have the no time requirement, and practices can do both, right? So for those of you watching that say, am I going to stick with CCM or am I going to switch to APCM? You don't have to pick. You could offer both programs in your organization. What you cannot do, though, is put a patient in both programs in the same month. But you can switch, right, Kathryn? So you can be an APCM 1 month, and maybe next month you had 40 minutes of CCM and you want to bill for CCM. And I think a lot of clinics may choose to do something like that.
Mm-hmm. I think there's definitely going to be some learning to figure out what is most advantageous, keeping a whole group of patients in one program, and then in APCM and another in CCM. But I like that it's not one or the other. You're right. There's a little bit of wiggle room here.
So a couple clarifications. We showed that list of 13 elements. That's not something you have to check all 13 boxes, right? It's a guideline of things you should cover, correct? In the 13 elements. So for those of you who saw that list, be like, wow, that's more things. This is not one of those programs where you have to do everything. But one of the things you do have to do is the patient has to consent to APCM. And so what we recommend here, you obviously have your patients that have consented to CCM or behavioral health or PCM. They will have to consent again for APCM. So because there's more programs like this, an approach that we really like is switching to an all-encompassing consent form. So instead of the form saying, or the verbal discussion, this can be verbal, instead of it saying, do you agree to participate in APCM? Imagine if it were phrased in a way that said, do you agree to participate in the care management programs offered at this organization, which may include chronic care management, behavioral health, APCM, RTM, RPM? So it would kind of give you an overall approach that then when you do want to pitch APCM, you're covered. Kathryn, what do you think about that approach? And should you consider it?
I really like this. I think sometimes clinicians are put in a sales role when they try and start explaining these programs, and that can take some of that pressure off. Especially the programs and the requirements can be a lot, can be confusing. So this is, I think, an opportunity to reduce all of that verbiage in a way that the patient can understand and be really excited about managing their health. I'm a fan of this one as well.
Awesome. So that's kind of our overview of APCM. We encourage every practice to consider it. Like all programs, the first year they're released, they tend to be a little bit on the basic side. This is one where we hope that over the years it gets better, particularly on the reimbursement rates for those first two tiers. The $15 not a whole lot, and even the $50 is less than CCM. So I really hope as we get closer to the value-based care transition that this one starts to be the model program for care management. So stay tuned. But again, this is a program that you might want to consider in 2025.